Rabies, a fatal but preventable disease. Rabies is an acute viral disease resulting in fatal encephalomyelitis in man and warm-blooded animals. The disease has terrified man since antiquity. The fear is because it is invariably fatal and the death in most instances is very agonizing and painful. However, if animal bites are managed properly, the disease and the death are preventable. Historically, the word rabies is derived from Sanskrit Indian word rabhas, means to do violence. It was Democritus who made the first recorded description of rabies about 500 years BC. Later, Celsius, in the 1st century, made the observation that the saliva of rabid animals was dangerous. In 1804, it was Zinck who, through his experiments, confirmed that the disease was transmitted through the saliva of rabid animals. However, the historical breakthrough was provided by Louis Pasteur. On 6th of July 1885 in Paris, France, he successfully used the nerve tissue vaccine developed by him and saved the life of a 9-year-old boy, Joseph Meister, who was severely bitten by a rabid dog.
This video film is prepared primarily for medical and veterinary personnel. It portrays the disease from an Asian perspective. The viewer should be able to 1. Explain the basic aspects of the cause of the disease, modes of transmission, and the clinical features of rabies both in man and animals. 2. Assess the risk of exposure and manage a case of bite by a rabid animal. 3. Advise preventive vaccination and ensure avoidance of rabies in the risk groups.
Epidemiology.
A recent 2005 World Health Organization survey shows that globally an estimated 55,000 persons die of rabies every year.
Of these, 31,000, that is 56%, are from Asia and 24,000, that is 44%, from Africa. An annual statistics available from some of the countries of Asia is as follows. India 20,000, which accounts for 1/3 of the global burden and 2/3 of Asian burden. China 3,000, Pakistan 2,490, Bangladesh 1,550, Philippines 248, Myanmar 196, Vietnam 86, Sri Lanka 76, Nepal 44, Indonesia 40, Thailand 11, Cambodia 2, Laos 2, Mongolia 2. In these countries, majority of rabies deaths occur among poor and illiterate, and children are more vulnerable to this disease. However, some countries in Asia like Japan, Singapore, Malaysia, Taiwan, and from other parts of the world, namely Australia, New Zealand, Scandinavian countries, and United Kingdom, are free from rabies. Epizootiology. The animal largely responsible for transmission of rabies in Asia is the dog. Besides, cats, monkeys, and wild animals such as mongoose, jackal, fox, and hyenas are also implicated. In the rural areas, rabies takes the toll of cattle, pigs, donkeys, sheep, goats, and other animals. In certain Latin American countries like Brazil and the Venezuela, vampire bats act as the hosts and the vectors. In some parts of the United States of America, skunks, coyotes, and raccoons are responsible for transmission of rabies. The rabies virus.
The rabies virus is an RNA virus. It is bullet-shaped and measures about 75 nanometers by 180 nanometers.
It can be seen only under an electron microscope. The virus envelope is made up of lipoprotein. From this envelope, numerous spikes project which are made up of glycoprotein, and these are necessary for viral attachment and also for inducing protective antibodies in the host. The virus is heat sensitive and gets destroyed in 5 minutes at 60 degrees Celsius and on exposure to direct sunlight. It can be inactivated by lipid solvents like iodine, phenol, Dettol, Savlon, alcohol, and beta-propiolactone. Modes of transmission. The rabies virus gets excreted in saliva, milk, and urine of the animal suffering from rabies. Most common modes of transmission are 1. Licks on wounds, 2. Scratches by rabid animals, and 3. Bites from rabid animals. Occasionally, rabies can be transmitted by 1. Aerosol infection, namely inhalation, especially in laboratories and in caves infested with rabies-infected bats. 2. Drinking raw milk of rabid animal. 3. Organ transplants, namely organs taken from the body of rabies-infected persons, like corneal transplant, kidney transplant, etc. It must be noted that the saliva of a rabid animal is infective 2 to 3 days before signs of rabies appear in the animal. Pathogenesis. The incubation period, namely the time interval between bite or exposure to rabies and onset of clinical signs in the person, ordinarily ranges from 2 weeks to 6 months in majority of cases. The incubation period may be very short, that is, less than a week, if the bite is over face, head, and neck. Rarely, the incubation period can be as long as 3 years or even more. The virus usually enters the body through the bite wound. Then it initially multiplies in the wound and muscles, and later enters the nerve roots. It travels along the nerve through axoplasm at the rate of 10 millimeters per hour. The rabies virus reaches the spinal cord and finally the brain. The virus undergoes further multiplication in the brain and gets disseminated to all parts of the brain. And from brain to various secretory organs like salivary glands, heart, reproductive organs, kidneys, and mammary glands. The virus cannot be detected in the blood till the end stage of the disease. That is, there is no viremia in rabies. Pathology. Despite 100% fatal nature of the disease, there are only minimal pathological changes in the brain. The brain is edematous, congested with perivascular coughing, gliosis with minimal neuronal damage. The presence of intracytoplasmic inclusion bodies, known as Negri bodies, found in the infected neurons of the brain is pathognomonic of rabies. But absence of Negri bodies does not rule out rabies and may not be seen in about 50% of brain samples. Clinical features. Rabies victims suffer horrifying symptoms and eventually die. Most pathetically, they know that the disease has no cure and they will die soon. The rabies victim dies a solitary death in isolation hospital ward, away from relatives, dear and near ones. The victim's hands are invariably tied to the cot by bandage or ropes. They are unable to drink even sips of water, undergo great pain and mental agony, and in most cases with full awareness.
The rabies in humans manifests in two forms: furious type, or classical hydrophobia, and paralytic rabies. Furious rabies is seen in about 80% of rabies cases.
Prodromal phase. Tingling and numbness are experienced at the site of bite 2 to 3 days before clinical symptoms appear. Later, low-grade fever, headache and body ache are reported. Clinically, subsequently, patient develops painful spasm of the muscles that control breathing and swallowing, resulting in drooling of saliva, and person cannot swallow and voice may get hoarse. The pupils may get dilated. Tears and perspiration increases. Blood pressure becomes low. Patient develops hydrophobia, fear of water. Photophobia, fear of light. Aerophobia, fear of breeze. Later, as the disease progresses, patient gets agitated, combative and destructive. Shows mental confusion, becomes sensitive to touch, noise and light, gets extremely thirsty but unable to drink because of painful spasms in the throat, develops dehydration, loss of muscle tone and listlessness is seen in majority, and eventually death occurs in 3 to 5 days due to respiratory paralysis or cardiac arrest. Paralytic rabies is seen in about 20% of rabies cases. Here also, initially, the patient experiences tingling and numbness at the site of bite 2 to 3 days before the clinical symptoms appear. Later, they develop early symptoms of fever, body ache and pain. Paralysis develops rapidly. It starts usually in the bitten leg and then spreads to the other leg and moves upwards. Person is unable to bear weight on legs, develops constipation and urinary retention, and later incontinence. Stupor, coma and death occurs in 7 to 14 days. In these patients, hydrophobia is usually absent and it may be difficult to diagnose this type of rabies if proper history of dog or animal bite is not elicited. The paralytic type of rabies is seen usually in patients who had taken some anti-rabies vaccination in the past. Laboratory diagnosis.
Laboratories play a main role in prevention and control of rabies. Firstly, we can diagnose if the bitten dog is rabied or not by examining its brain. Then, we can decide if the patient needs to be vaccinated or not.
Only the fresh brain samples of rabid animals are to be transported within 2 to 3 hours to the nearest designated laboratory. If there is a delay, then it can be put in 50% glycerol saline and transported as soon as possible. In addition, cerebrospinal fluid, CSF, and saliva can be transported in cold chain for antigen detection or RNA detection by polymerase chain reaction, PCR, and also for virus isolation. Rabies antibodies can be detected in sera and CSF. Antemortem diagnosis of rabies can be made on saliva samples using virus isolation or RNA detection. Skin samples, that is frozen section, sent on dry ice may be tested for antigen detection, and CSF sample for virus isolation or RNA detection. However, no single test is 100% sensitive and a negative test doesn't rule out the possibility of rabies. Post-mortem diagnosis of rabies can be made by examining brain samples for detection of Negri bodies by cellular stain, antigen detection by fluorescent antibody test FAT, virus isolation by mice inoculation or cell culture technique, or viral nucleic acid detection by RT-PCR technique. The most widely practiced method is FAT. Assessment of exposure and recommended treatment.
After After thorough wound toilet, we must now classify the wounds according to WHO categorization. This will aid in the determination of the most appropriate post-exposure prophylaxis.
According to a recent recommendation of World Health Organization 2007, there are three categories of exposure. Category 1 exposure. 1. Touching of animals. 2. Feeding of animals. 3. Licks on intact skin. Recommended treatment. In these types of exposures, since there is no risk of developing the disease, no treatment is recommended. However, if they have pets, they can be advised pre-exposure vaccination. Category 2 exposure. Minor scratches, abrasions with superficial nibbling of skin not associated with bleeding. Recommended treatment. As this is an exposure carrying minor risks, local treatment of wounds and a course of anti-rabies vaccine are advised. Category 3 exposure. 1. Single or multiple wounds with breach in the skin and bleeding. 2. Licks on broken skin and mucous membranes. 3. Bites from bats and wild animals. Recommended treatment. As this is an exposure carrying severe risk, local treatment of wounds, administration of rabies immunoglobulin and a complete course of anti-rabies vaccine are advised. Post-exposure prophylaxis (PEP). Wound management. The animal bite victims should first wash the bite wound and rabies exposed parts thoroughly under running tap water and using detergent or soap for at least 10 minutes. This removes and inactivates the virus present in the wound to a great extent. This is a very important first aid measure that should not be neglected by animal bite victims. Then they have to gently wipe the wound and can apply any household antiseptic like Dettol, Savlon, povidone iodine or spirit. Local applicants like turmeric, plant juices and coffee or tea powder should not be applied. Animal bite wounds are not to be bandaged, and if unavoidable, it should be loose and not occlusive. Normally, animal bite wounds are not sutured, as the needle puncture and suturing material may carry the virus deeper and leads to many puncture wounds for the virus to enter. If the wounds are extensive and there is a need to suture, it should be delayed for several hours to 3 days. The number of sutures should be minimum and to be applied loosely to facilitate free bleeding and drainage. Before suturing, anti-rabies serum or rabies immunoglobulin should be infiltrated into all animal bite wounds. Rabies vaccines. The vaccines derived from the nerve tissue have been discontinued from most countries of the world, including Asia, except from Pakistan, Bangladesh and Myanmar.
Currently, 4 types of modern vaccine are available for use in man, namely 1. Human diploid cell vaccine HDCV, 2. Purified chick embryo cell vaccine PCEC, 3. Purified virocell rabies vaccines PVRV, 4. Purified duck embryo vaccine PDEV.
These are safe, less painful, almost 100% efficacious and with negligible adverse effects. The rabies vaccine can be administered either by intramuscular or intradermal route. 5-dose intramuscular regimen or SN regimen. Administer the vaccine on days 0, 3, 7, 14 and 28. 0 day means the day on which first dose of vaccine is given and not the day of bite. The 6th dose on day 90 is optional and is in vogue in some countries. Site of vaccination. For adults, it is the deltoid muscle in the upper arm. In young children, it may be given into anterolateral thigh region. The vaccine should never be given in the gluteal region, as the fat deposition in gluteal region may hinder absorption of vaccine. Abbreviated multi-site intramuscular regimen 211 or Zagreb regimen. Administer one dose of vaccine intramuscularly into the left and one into the right upper arm, deltoid region, on day 0, followed by one dose into the upper arm, deltoid region, on days 7 and 21. This schedule saves 2 clinic visits and 1 vaccine dose. Dose of PVRV is 0.5 ml and the rest, namely HDCV, PCECV and PDEV, are 1 ml vaccines. Intradermal rabies vaccination or IDRV. The IDRV involves deposition of rabies vaccine or antigen in the layers of dermis of skin. The antigen processing cells or Langerhans cells subsequently carry it to reticuloendothelial system and elicit a quicker and higher antibody response. There are 2 regimens. Updated Thai Red Cross intradermal regimen or 2 sites or 22202 regimen. 0.1 ml of cell culture vaccine is given at each of 2 sites on the deltoid area. (0.1 ml into 2 sites on days 0, 3, 7 and 28. There is no vaccination on day 14. This regimen must be combined with RIX when administered to patients with severe exposures.
The vaccines approved by the national authorities must be used for this regimen. However, WHO approves only PVRV Verorab of Sanofi Pasteur and PCECV Rabipur of Novartis vaccines for administration by this regimen.
8-site intradermal regimen 804011. 1 dose of 0.1 ml is administered intradermally at 8 different sites: upper arm, suprascapular region, lower quadrant of abdomen and lateral thighs on day 0. On day 7, 4 0.1 ml injections are administered intradermally into each upper arm, deltoid region and each lateral thigh. Following these injections, 1 additional injection of 0.1 ml dose is administered on days 28 and 90. This regimen produces a higher antibody response than other regimens by day 14 and must be combined with RIX when administered to patients with severe exposures. The vaccines approved by the national authorities must be used for this regimen. However, WHO approves only HDCV Imovax of Sanofi Pasteur and PCECV Rabipur of Novartis vaccines for administration by this regimen.
It is very important that intradermal rabies vaccination is given in specialized or designated centers and administered by trained personnel only. The reconstituted vaccine vials must be stored between 2 to 8 degrees Celsius and used up as early as possible, but at least within 8 hours. Rabies vaccines formulated with an adjuvant should not be administered intradermally.
Rabies immunoglobulin, anti-rabies serum, RIX. RIX are indicated in all category 3 severe exposures. These are to be infiltrated locally into all wounds on day 0 along with first dose of anti-rabies vaccine. RIX are life-saving in severe bites. Rabies immunoglobulin provides passive immunity, that is, they neutralize the virus present in the wound and provide ready-made rabies antibody before active response to rabies vaccine. Rabies vaccines take 10 to 14 days to elicit sufficient protective antibody titer. Hence, it is essential that all category 3 exposures are treated with RIX as they provide protection during this vulnerable short incubation or window period. RIX are always to be given along with vaccines and never alone. Anti-rabies vaccine should be given at a site away from the site of rig infiltration to prevent in situ neutralization effect. Two types of rigs are available. A. Equine rabies immunoglobulin, ERIG. These are derived from immunized horses. The recommended dosage is 40 IU per kg body weight. These are available in 5 ml vials with potency of 200 or 300 IU per ml or differently depending on the producer. Prior skin sensitivity test needs to be done before the full dose administration. B. Human rabies immunoglobulin, HRIG. These are of human origin and safe. The recommended dosage is 20 IU per kg body weight and available as 2 ml ampule with a potency of 150 IU per ml. There is no need for skin sensitivity test before full dose administration of HRIG. Administration of ERIG. Skin sensitivity test. A skin sensitivity test must be done prior to administration of ERIG. That is, 0.1 ml of ERIG is diluted with 0.9 ml of sterile normal saline. Later, 0.1 ml of 1:10 diluted ERIG is injected intradermally into the flexor aspect of forearm as test dose. The patient is observed for about 10 to 15 minutes for local and systemic adverse reaction. If the patient has no adverse reaction to test dose, then full dose of ERIG can be given under due precautions. If the skin sensitivity test is positive, that is induration with erythema of greater than 10 mm with or without systemic reactions, then HRIG should be given. If the patient cannot afford HRIG and a situation is life-threatening, then after obtaining signed consent of the patient, ERIG can still be given in an institutional setup after pre-medication with antihistamines and short-acting steroids. The emergency medicines like injection adrenaline, injection hydrocortisone, injection antihistamine, intravenous fluids, and oxygen should be kept ready to manage emergencies like anaphylaxis. Administration of full dose of RIGs. The required dose of RIGs must be computed according to the body weight of the patient. It shall be removed from the refrigerator and brought to room temperature before injecting. Using 26G or 24G needles, RIG is infiltrated carefully with minimum traumatization into and around all the wounds. If the volume of RIG is not sufficient to infiltrate all the wounds, it may be diluted with sterile normal saline to a volume sufficient to infiltrate all wounds. After infiltration of all wounds, any remaining RIGs should be injected intramuscularly into thigh region or to a site away from vaccine administration. Ideally, RIGs has to be given along with the first dose of rabies vaccine. If it cannot be done for some unavoidable reasons like non-availability, then it can be given up to the 7th day after the first dose of vaccine. Prescribed dosage must not be exceeded and it is given only once. Otherwise, it may interfere with the development of active immunity following vaccination. Failure to use RIGs has been one of the reasons for the rabies deaths despite the use of modern vaccines. Advice to patients.
There is no restriction on diet.
There is no restriction on diet, but alcohol intake should be avoided or restricted during the course of treatment. The patients have to be advised to complete the course of treatment and not to default. They have to consult the doctor in case of any adverse drug reaction or for any concomitant intake of drugs.
Re-exposure vaccination. Those patients who have taken 3 doses of ARV as pre-exposure vaccination or complete course of 5 doses of post-exposure prophylaxis any time in the past, if they get exposed to rabies subsequently, need only 2 doses of modern vaccine on days 0 and 3, and there is no need for rabies immunoglobulin. Patients with previous history of nerve tissue vaccine are to be treated as fresh cases. Special situations. 1. For patients with HIV/AIDS other immunocompromised people like those undergoing treatment suffering from malaria, cancer, liver cirrhosis, or under steroid therapy. It is important that wound washing and administration of RIGs are done properly in these patients, as these are life-saving, and a complete course of anti-rabies vaccine are advised. 2.
It is advisable to double the first dose of vaccine in the following situations: patients who seek treatment after a delay of 48 hours or more, people with high-risk exposure or extensive wounds, namely on head, neck, face, hands, and genitalia following bites by suspect or confirmed rabied animals, in patients where RIG is indicated but is not available.
3. Persons exposed to rabies after drinking milk of rabid animal. There is no need for post-exposure prophylaxis if the milk is pasteurized or consumed after boiling. However, if the milk consumed is raw, then as post-exposure prophylaxis, a full course of vaccine is indicated. 4. Those having cuts or abrasions on hands, fingers, etc. and get exposed to secretions of rabid animal, saliva, urine, must receive full course of vaccine along with RIGs as post-exposure prophylaxis. 5. As rabies is 100% fatal, there are no contraindications to post-exposure prophylaxis. Pregnant women and lactating mothers following animal bites can safely take anti-rabies vaccines and RIGs, as no adverse effects on the fetus or suckling baby has been reported. Important points to remember. 1. Dosage of vaccine is same for all age groups and they can be given along with other vaccines. 2. Anti-rabies vaccines are to be reconstituted using only the diluents provided with the vaccine. Any other chemical or biological substances are not to be used for reconstitution. 3.
All modern vaccines like
HDCV, PCECV, PVRV, and PDEV are interchangeable. But unless the situation warrants, it is advisable to stick to one type or brand of vaccine only, as it will be difficult to attribute any adverse effects or treatment failure to any one vaccine. In persons who are allergic to chick or duck eggs, it is advisable to use human diploid cell vaccine or purified vero cell rabies vaccine only.
4. There is no single shot or one dose of ARV available anywhere in the world. Or is there a vaccine that confers lifelong immunity? Pre-exposure vaccination. Anybody can be a victim of this deadly virus, but some are at a greater risk of exposure, and there is a need to create awareness and advice for pre-exposure or preventive vaccination. People like veterinarians, pet owners, butchers, municipal dog catchers, laboratory staff working with rabies virus, people treating, looking after rabies victims including relatives and hospital staff, postal and courier personnel, children who love and touch animals, travelers going to rabies endemic areas, and animal welfare activists. These people need to take pre-exposure anti-rabies vaccines to prime their immune system and maintain sufficient antibody titers. Only modern vaccines are to be used for pre-exposure vaccination either by intramuscular route or intradermal route using 0.1 ml at one site only. The schedule is 3 primary series of injections on days 0, 7 and 21 or 28. Rabies in animals.
Animals such as dogs, cats, foxes, mongoose, and jackals act as reservoirs for rabies virus. They not only transmit the virus to humans but also succumb to the rabies. Dogs, because of their close association with human beings, act as the major vectors of rabies, to the extent over 95% of rabies transmission is through dogs only.
Rabies in dogs occurs in 2 forms, namely furious and dumb rabies. Furious form of rabies. In these animals, there will be marked changes in their behavior and temperament. They get excited, agitated, and wild. Dogs become overtly aggressive, which results in many more bites than usual. They lose fear of natural enemies. Facial expression will be alert and anxious with dilated pupils, and they run amok and bite other animals or humans encountered. They indiscriminately bite inanimate objects like sticks, wood, chain, utensils, stones, etc. Fear of water or hydrophobia is typically absent in animals. If they are unable to drink water, it is because of paralysis of jaw muscles. They follow moving objects and try to bite and run around aimlessly. Dumb form of rabies. It is difficult to diagnose as classical symptoms exhibited in furious forms are absent. The behavioral changes are minimal or absent. Paralysis of throat, masseter muscles, and dropping of lower jaw is seen. Profuse salivation and drooling is seen. Animals are not aggressive and rarely attempt to bite. Paralysis progresses rapidly, causing coma and death. In case of cats, they get very furious, attack suddenly, bite and scratch viciously. Hence, scratches by cats are equally dangerous as bites. Vaccination against rabies in animals. The currently available modern vaccines are given to pups and kittens as a primary course of one dose each at the age of 3 and 4 months. Subsequently, a booster dose is given every year.
There is no scope for post-exposure prophylaxis in dogs, cats, and other animals exposed to rabies in enzootic areas, and such animals need to be kept under observation or euthanized and subjected to laboratory examination for confirmation of rabies.
Personal safety against rabies. Do not touch the fomites, that is, leash, foot plate of an animal suspected or proven of rabies. Wear gloves, masks, glasses, and long-sleeved overall while examining rabid animals. All instruments must be sterilized either by placing them in a strong antiseptic solution or by autoclaving. Don't try to examine the mouth of a pet or farm animals with bare hands. Always use gloves. Avoid contact with saliva, urine, tears, semen, and vaginal secretions of a rabies patient. Do not touch animal bite wounds with bare hands. Use gloves. None of the herbal or traditional medicines is effective against rabies. Always go for anti-rabies vaccines and immunoglobulins as and when necessary. Take pre-exposure vaccination if you are in constant touch with animals. Provide pre-exposure vaccination to veterinarians, pet owners, municipal dog catchers, medical staff, laboratory staff, postal and courier personnel, and travelers going to rabies endemic areas. Frequently asked questions. Can local antibiotics or antimicrobials be applied to the animal bite wounds?
After cleaning the wounds, local antibiotics or antimicrobials, wherever indicated, can be applied to the animal bite wounds.
Is there a carrier state of rabies in dogs? What is its relevance to observation of dogs for 10 days after it has bitten an individual?
The carrier state of rabies in dogs is reported in experimental conditions and is considered to be a freak of nature. Besides, such dogs secrete the virus intermittently, and that too in very low titers, considered not adequate for infection. Hence, the observation of the dog for 10 days and simultaneous post-exposure prophylaxis of the bitten person is considered appropriate by the World Health Organization in 2007.
What is the criterion for protection after anti-rabies immunization? How can it be known?
According to the World Health Organization, an anti-rabies antibody titer of greater than or equal to 0.5 IU in the vaccinated individual is considered as protective. However, as this test is sophisticated, only a few selected centers in every country will be able to do it.
Summary. Rabies is an acute viral encephalomyelitis caused by a bullet-shaped RNA virus and is practically 100% fatal. According to a recent estimate of World Health Organization, globally about 55,000 persons die of this disease every year, of which 31,000, that is 56%, are from Asia and 24,000, that is 44%, from Africa. India alone accounts for 20,000, that is 36%, human rabies deaths annually. The main vector of rabies is the dog, and other animals include cats, fox, jackals, mongoose, hyena, etc. The common modes of transmission are through bites, scratches, and licks of rabid animals. The usual incubation period is about 2 weeks to 6 months and could vary up to 3 years in rare cases. The disease in man presents in two forms, namely classical furious type, that is 80%, exhibiting hydrophobia, fear for water, aerophobia, fear for breeze, and photophobia, fear for light. The other less frequent type of paralytic rabies, that is 20%. The exposure to rabies is categorized into 3 types, namely Category 1, that is no risk, Category 2, involving moderate risk, and Category 3, severe risk. In case of Category 1 exposure, there is no need for any anti-rabies treatment. In Category 2, wound management and vaccines are used. And in Category 3, wound management, rabies immunoglobulins, and vaccines are used. Currently used modern vaccines include the cell culture vaccines, that is, human diploid cell vaccine, purified chick embryo cell vaccine, purified varicocele rabies vaccine, and the purified duck embryo vaccine. The vaccines approved by the national health authorities and World Health Organization are administered by intramuscular and intradermal regimens. Rabies immunoglobulins are life-saving in Category 3 or severe exposures. Pre-exposure vaccination is recommended to those in constant touch with animals in rabies endemic countries and those handling rabies virus in laboratories. In previously immunized individuals, following re-exposure to rabies, only 2 doses of vaccine is needed and rabies immunoglobulins are not required.
I thank you for viewing this video film, and I hope you found it educative and interesting.